Alright guys, so this is going to be your lecture on spinal cord injury, and this is chapter 20 of your O'Sullivan book. Please make sure that you either have a handout with you, you have your book with you, or some paper to write down some key words that I'm going to be mentioning throughout the presentation or highlighting them on your PowerPoint, as well as making notes for yourself on things that may not appear on the slides but are very important. I also suggest you read the chapter. Alright, so spinal cord injury is defined as a partial or complete disruption of the spinal cord, which results in paralysis, sensation loss, altered autonomic function, and reflex activity. The spinal areas that are most frequently injured are C5, C7, T12, and L1. And spinal cord injury has two causes. It can be traumatic due to motor vehicle accidents, falls, stabs, or gunshot wounds, or it can be a non-traumatic cause, which can be due to a pathological disc prolapsed, vascular insult or dysfunction, complications due to osteoporosis or rheumatoid arthritis. It can be caused by complications of degenerative joint disease, neoplasms, abscesses, neurological diseases such as multiple sclerosis or amyotrophic lateral sclerosis, which we're going to be talking about later on in the course. Some demographics to have in mind when thinking of spinal cord injury: there are approximately 17,000 new cases annually in the United States. There are between 243,000 to 347,000 individuals with spinal cord injury in the United States. Men are more affected than women, with a ratio of 80% to 20% women. Whites, more than African Americans, Hispanics, and Asians are affected. The average age for spinal cord injury is 42 years of age, with the first peak being at 15 to 29 years of age, and this is mostly due during those ages due to motorcycle accidents or motor vehicle accidents. That's where the first peak of incidence for spinal cord injury, with the second peak being those older than 65 years of age. And this is mostly due to falls. And the older the individual gets, the more risk they are for falls, therefore the more risk they are for spinal cord injuries. Life expectancy has increased over the years, and that just correlates with the increased advances that we have made in the medical field over the years. So we are better suited to treat these individuals, therefore life expectancy has increased as well. As I discussed a couple slides back, the etiology or the cause of this can be traumatic and non-traumatic. Trauma is the most frequent cause of injury. These traumatic spinal cord injuries are secondary to motor vehicle accidents, motorcycle accidents, falls, violence, or like I said before, gunshot wounds or stab wounds. GSW stands for gunshot wounds, or it can be a sports injury. The non-traumatic causes in adults result from disease or pathological influence, and this accounts for about 38% of spinal cord injuries. 56% of cervical lesions will lead to tetraplegia, which is the same as quadriplegia. And we're going to be talking a little bit more about what those mean. And 43% of the injuries are thoracic, lumbar, or sacral, which will lead to paraplegia. Incomplete tetraplegic injuries are most common, followed by complete paraplegia, incomplete paraplegia, and complete tetraplegia. So this is just giving you the most common injuries in the order of how often they happen. With that said, with the etiology, the length of stay in acute care has decreased from 24 days in the year 1970 to 11 days in the year 2016. And this may be due to how much knowledge base and how much better the care has been over the years. The length of stay in an inpatient rehab facility has also decreased from 98 days to 35 days. Again, these are just all interesting facts, and it just goes to show how much our knowledge base in the medical field has gotten better at treating these patients, as well as we have to also take into consideration how much insurance has changed over the years as well, and the limits that these insurance companies are putting on this patient stays in acute care settings and inpatient rehab settings has decreased over the years as well. So we have to take that into consideration. Okay, guys, so the following slides are going to be a review, and if you are not feeling comfortable with the basic anatomy of the spine, I would suggest you go back to your pathophysiology book, your anatomy book, just to review, but I will be covering some of the information obviously on the slides. So with that said, spinal nerves exit below the corresponding level of the spine, the exception being that not all of the cervical ones are going to follow this rule. So C1 through C7, their spinal nerve roots exit above their corresponding spinal level, and C8 is the only one that is going to exit below spinal level C7. There are 31 pairs of spinal nerves. There are 8 cervical, there are 12 thoracic, there are 5 lumbar, and 5 sacral, as well as 1 coccygeal. Extremely important key information that you should know that the spinal cord ends about L1 to L2. At the lower border of L1, the spinal cord tapers into the conus medullaris, and the cauda equina is that distal portion of cord that is a bundle of nerve roots from L2 to S5. This is responsible for innervating the pelvic organs as well as the lower extremity. So it is important to note that spinal cord injuries commonly result from fractures of vertebrae C5 through C6, but they never really happen so much at L3 to L5. With that, and knowing the anatomy of the spinal cord and knowing that the cauda equina is from L2 to S5, typically when there is a need to extract cerebral spinal fluid, or there's a need to give anesthesia for an epidural if somebody is, if a female patient is giving birth, or if they have to do a lumbar puncture for anything. Typically, this is done between the levels of L3, L4, L4, L5, because there really is no risk of accidentally injuring the spinal cord and causing a spinal cord injury. So this is just important to know that this is why they do these procedures at such low levels, because we know that the spinal cord ends about L1, L2, and then it becomes the cauda equina. Alright guys, so as it says there on the slide, this is a very important slide. You must know this. No going around it. You have to make sure that you know the innervation points that are listed on the slide, because knowing these and knowing what level our patient's spinal cord injury is at then that gives us an idea of what the patient has available to for us to work with. So as you see here on the slide, C3 and C4 are going to be innervating the diaphragm. Then we have C5, which is the deltoid and the biceps. At C6, we have the wrist extensors. C7, we have the triceps. From C8 to T1, we have the hands. Then we have from T2 all the way down to T7 are going to be the internal and external intercostal nerves. From T8 to T12, we have the nerves that provide the abdominal region. At L2, we have the hip flexors. L3, we have the knee extensors. L4, the ankle dorsiflexors. L5, we have great toe extension. S1, we have the ankle plantar flexors. S2 through S5 are going to be responsible for the bowel, bladder, and sexual function. So, however you may choose to study these, but make sure that you have either flashcards if you want to study directly from this slide, but you need to know where the spinal nerves exit below their corresponding level of the spine. Again, the only exception is that cervical spine, where C1 through C7 are going to exit above their corresponding spinal level. But please make sure that you are very, very comfortable with this slide. Alright guys, so this is another very, very important slide. This is very telling as to what your patient is going to be able to do depending upon where the injury was. So if I say in a question, your patient had a spinal cord injury at C5, you need to tell me what the patient is able to do based off of what muscle is being innervated at that spinal level. So you would be able to tell me that the patient is able to use their biceps. Versus if I ask you the same question, my patient has an L2 spinal cord injury. What is my patient able to do at this level? So you would be able to tell me that the psoas is functioning at this level, therefore my patient may be able to perform some hip flexion. So you have to know this in order to know what your spinal cord injury patient has control of. So in this slide, we are going to be discussing a little bit of the Asia scale. The individuals that you may come across with spinal cord injuries may have variable clinical presentations in terms of what they have available as far as motor goes or as far as sensory function below that neurological level. So this scale is called the Asia scale, and it was created to distinguish among different types of spinal cord injury. So is it complete? Is it incomplete? Is it sensory incomplete? Is it motor incomplete? There are different levels on this scale, and this is a tool that the medical doctor uses to classify the patient's type of spinal cord injury. Physical therapists also provide input as they're treating the patient to see if if there is a change in the patient's Asia scale assignment from when the physician assigned that first classification. So you are going to be seeing this scale throughout the presentation a couple more times, and we're going to be talking a little bit more in detail about it. So here we are going to talk about the classification of spinal cord injuries, and your patient is going to fit into one of these two broad functional categories. So these words here, I want you to make sure that you are very, very familiar with defining them. If you're not, make sure that you start a vocabulary list so that you can add these words too. Your patient is either going to be a tetraplegic or quadriplegic, which is the same, which means that this patient had a lesion of the cervical spine. Therefore is going to lead to complete paralysis of all four extremities as well as the trunk, and may include the respiratory muscles as well. So the chart to the diagram to the right is a really good visual of what a tetraplegic is going to be looking like as far as to what is paralyzed. So you have the C4 injury where everything that is in the blue is going to be paralyzed, and a C6, everything in the blue here is going to be paralyzed. So that includes the trunk, that includes both upper extremities and bilateral lower extremities. Here the patient may have their respiratory muscles, but it's hard to say. This is just a diagram kind of showing you what constitutes a tetraplegic or quadriplegic. Then we move on to the paraplegic, which means that there may be complete thoracic, lumbar, or cauda equina lesion. Now, in this patient, they will present with all or part of the trunk and lower extremity paralysis. It is very important to note the level at where paraplegia starts. So important to know that T6 level, anything below that T6 level is going to be leading to paraplegia. Okay, so as you see here in the blue, the trunk and the lower extremities are paralyzed, and with an L1 injury, the lower extremities are paralyzed here. So it's a nice diagram that kind of gives you an illustration as to what is available in that patient and what is lost with that lesion. Now, this slide further classifies the injuries into complete injuries, and in future slide we're going to talk about incomplete injuries. So complete injuries, the ASIA scale defines a complete injury as having that patient having no sensory and no motor function below the neurological level, meaning both. So it can't be that the patient has sensory, but they don't have any motor component or motor function, not component. It has to be both. For it to be considered a complete spinal cord injury, there has to be no sensory and no motor function below that neurological level or that level of lesion. This includes the lowest sacral segments S4 and S5 dermatome. There is no sacral sparing, and we're going to be talking about sacral sparing and the meaning of that in this same slide. For this patient, sensory and motor of these segments are determined by sensation in the anus and voluntary anal sphincter contraction. So sacral sparing, as you know from this slide now that there is no sacral sparing, is determined by the function at S4 and S5 dermatome. So this patient, if there is sacral sparing, they are able to feel deep anal pressure or voluntary anal sphincter contraction. So this may be a big indicator of how good of a prognosis the patient has, and it's very, very important information to know in rehabilitation. Okay, so just to recap, the important classification of a complete injury is that there is no sensory and no motor function below the neurological level, meaning that there cannot be sensory, but there is motor. That doesn't happen in a complete injury. In a complete injury, there is absolutely no sensory and no motor, as well as there is no sacral sparing, meaning that that patient is unable to feel deep anal pressure or voluntarily contract their anal sphincter. Incomplete injuries, the ASIA defines an incomplete injury as having sensory and or motor function below the neurological level. This includes sensory or motor at S4 and S5 level. Because there may be sensory or motor at S4 and S5, there is going to be sacral sparing. Therefore, that patient will have the ability to either feel deep anal pressure or voluntarily contract their anal sphincter. So, recapping here, a complete injury, no sensory, no motor below that level of neurological compromise, and no sacral sparing. When we talk about an incomplete spinal cord injury, we are talking based upon the ASIA scale as having either sensory and or motor function below that neurological level, as well as the presence of sacral sparing. All right, and then we have zones of preservation or zone of partial preservation, which typically applies to incomplete spinal cord injuries. As you know, an incomplete spinal cord injury is classified as having motor and or sensory function below the neurological level, but it also has that presence of sacral sparing because there is function, sensory and or motor function at S4, S5. Now, if an incomplete injury has that motor and or sensory function below the neurological level, but it does not have sacral sparing, then the areas below the neurological level are going to be called zones of preservation, or your book calls them zones of partial preservation. So basically, it just is a classification that the ASIA defines these areas that the patient has below the neurological level of motor and or sensory function, yet this specific patient does not have sacral sparing. So they are not able to contract their anal sphincter and they're not able to feel deep anal pressure. So that's what differentiates the incomplete injury classified as zones of preservation. It's because this is an incomplete injury, but the patient does not have that sacral sparing. So that's why the terminology is a little different for those areas of intact motor and sensory function below the neurological level. You can read a little bit more about this on page 859. The title of that paragraph is Complete Injuries, Incomplete Injuries, and Zone of Partial Preservation. So in this slide, we're going to talk about how does the doctor, the physician, figure out what the patient's ability is, what the patient's designation of spinal cord injury level is, what the neurological level is going to be. And ASIA stands for American Spinal Injury Association. It has international standards for neurological classification of spinal cord injury, and it is a standardized tool to determine the severity of injury in our patients with spinal cord injury. So, how affected is their motor and sensory? How much motor and sensory loss do they have after this spinal cord injury? So, the doctor has to see what the neurological level is, which means which is the most caudal or the lowest level of spinal cord with normal motor and sensory function on both the right and left sides. What is the most caudal or lowest segment that has the normal motor function bilaterally as well? And they have to figure out the sensory level by assessing which is the most caudal or the lowest segment with normal sensation function bilaterally. So they have to assess all these things using myotomes to check for the motor level, the most caudal motor level, and what and dermatomes for sensory level to assess that as well. In order to figure out and assign a level of spinal cord injury or the neurological level, as the previous slide stated, for the motor level, the most caudal segment with normal motor function has to be identified. So, an example that I want to give you is the patient is being assessed to see if they are able to perform elbow flexion, full range of motion against gravity without any resistance. So, the patient performed it. There are at least a 3 out of 5 in the biceps. You know that the biceps is innervated by C5. So, in order for this patient to be classified as a C5 spinal cord injury, all of the muscles, the next most rostral key muscles, have to be a 5 out of 5. Rostral just means anything above that muscle, meaning anything closest to the face. So the anterior deltoid, the upper trapezius has to show a 5 out of 5 in order for that patient to be classified a C5 spinal cord injury. I'll give you another example. So the patient has a the patient is being assessed for hip flexion and they are able to perform hip flexion against gravity, full range of motion, obviously without any resistance. So they are a 3 out of 5 in the hip flexors. You know that the hip flexors are innervated by L2. In order for that patient to be classified an L2 spinal cord injury, every muscle that is rostral or the next most rostral key muscle has to show a 5 out of 5. Therefore, the abdominals, a 5 out of 5, all the muscles of the upper extremity, 5 out of 5, in order for that patient to be classified as an L2 spinal cord injury. For those myotomes that are not clinically testable, as you see the ones in the parentheses, the motor level is defined the same as the sensory level. To assess for the sensory level, we also are looking for the most caudal segment with normal sensation, and this is assessed via light touch or pinprick on bilateral sides. Scoring is using a 3-point ordnance scale where 0 is absent sensation, 1 is impaired, and 2 is normal. We are looking for 2 in order to see which is the most caudal or the lowest segment with normal sensation. So when we determine the neurological level, there may be differences in motor and sensation levels from left to the right side. In this case, where there is a lot of discrepancy, it is typically not appropriate to assign a single neurological level because it can be misleading to what the patient can actually do, or it may limit them as far as their diagnosing. So each level should be documented separately. Okay, guys, so now we're going to talk about the Asia Impairment Scale. This is on page 859, table 20.1 of your book. So we're going to use the example that we talked about in the prior slide where we classified the patient with that 3 out of 5 in the biceps, and everything above that biceps in the muscles are 5 out of 5. So we classified that neurological level as a C5 for the motor. So let's talk about the Asia classifications. So with A, we have that patient that has a complete injury at C5 level. There is no motor, no sensory function preserved, or anything preserved in the sacral segments S4 or S5. So this would be classified as a C5 level A or C5 complete according to the Asia Impairment Scale. Letter B is that patient. Let's use the same example. We have a C5, which the biceps are 3 out of 5. Everything rostral to that is going to be a 5 out of 5. There is sensory, but no motor function below that neurological lesion, and that includes the sacral segments S4 and S5. So there is going to be sacral sparing here, but there is no motor function below that biceps. So the biceps is the only muscle that is going to be a 3 out of 5. Everything above that is going to be 5 out of 5. This would be a C5 level B or a C5 sensory incomplete. Then we have motor incomplete, which is C. So now let's talk about that same example that we've been talking about. Now, motor function is preserved below the neurological level, and more than half of the key muscles below the neurological level have a muscle grade of less than 2. So with that same example, you're going to use where the biceps is a 3 out of 5, everything above it is a 5 out of 5, but the wrist extensors are a 2 plus out of 5, the psoas is a 2 minus out of 5. So everything below the level that we classified that patient as is going to be lower than a 3 out of 5. Therefore, we cannot go any further down because everything is lower. It has to be, remember, 3 out of 5, and then everything above it has to be a 5 out of 5. So this would be classified as a C5 class C or a C5 motor incomplete. And also know that with motor incomplete, S4 and S5 are spared as well. So there is sensation there. Then we have D, which is now a little different because motor function is preserved below the neurological level, and at least half of the key muscles below the neurological level have a muscle grade of 3 or more. So an example, using that same case that we've been using, this patient we classified as a C5, has a 3 out of 5 at the biceps, but now everything below that level, so we'll say the wrist extensors are a 3 out of 5, the trunk is a 3 out of 5, but we cannot use those levels as the most caudal level because everything above that is not a 5 out of 5. So if we said that the wrist extensors are 3 out of 5 and we wanted to use that as the level, Everything above the wrist extensors has to be a 5 out of 5. But in this specific case, the biceps is not a 5 out of 5. So this would be a C5 class D on the Asia scale, or C5 motor incomplete. And then we have class E, which is normal. This patient has normal motor function as well as normal sensation. So this patient is a class E or normal. All right, guys, so this is once again the Asia scale. As you see on the left side, you have the motor, and on the right side, you have sensory. Sensory would be assessed. Obviously, we're looking for the most caudal segment where there is normal sensation. Here you have the ordinal scale that we were talking about. The doctor would just go down the list on both sides and see which level the patient the sensation diminishes, or what is the most intact caudal segment. Using that pinprick and that light touch, you have a little cheat sheet there with the dermatomes. You would do the same to grade the motor level. You would go towards the most caudal intact motor myotome. So we've been working with C5 as one of our examples. So this patient has a 3 out of 5 for the elbow flexors, and everything above that is 5 out of 5. Therefore, the patient is classified as a C5 neurological level. So here we would put the neurological level on both sides, whether it's a complete or incomplete injury, what classification on the Asia impairment scale from the slide that we just went over from A through E, and then if there are any zones of partial preservation as well, and on which side. All right, guys, so at this point of the presentation, I want to make sure that you have understood some of the information, hopefully most of the information. Obviously, there will be a question and answer session where you will review some of this information with me. At this point, you should be able to feel comfortable answering these questions. So, what is sacral sparing? What are the most common causes of spinal cord injury? What is the cauda equina? What is innervated at each level? What is the Asia scale? What is paraplegia and tetraplegia? How is a complete injury defined? What are the zones of partial preservation? How is an incomplete injury defined? How many spinal nerves are there in each segment? What spinal level changes from a quadriplegic to a paraplegic? If a muscle is a 3 out of 5 and all muscles rostral to it are 5 out of 5, what are you defining? Define the classifications of the Asia scale. So now we're going to talk about spinal cord injury syndromes, and these are several syndromes that have emerged with consistent clinical features. Damage to specific areas of the spinal cord can result in unique sensory and motor clinical pictures. And based off of this presentation, these spinal cord injuries have been classified into these specific syndromes, such as Brown-Séquard syndrome, central cord syndrome, posterior cord syndrome, anterior cord syndrome, and cauda equina injuries. So Brown-Séquard syndrome is a lesion, an upper motor neuron lesion that is caused by penetration wounds, post gunshot or stab wounds. The characteristics of this are going to be ipsilateral loss of the dorsal columns with loss of tactile discrimination, pressure, vibration, and proprioception. There's going to be ipsilateral loss of cortical spinal tracts with loss of motor function and spastic paralysis below the level of the lesion. There's going to be contralateral loss of the spinal thalamic tract. As you know, the spinal thalamic tract is responsible for pain and temperature. So there's going to be loss of that pain and temperature below the level of the lesion. Please know the upper motor neuron lesion this is classified as. The following we're going to talk about is central cord syndrome. This is the most common spinal cord injury syndrome. The typical cause is cervical hyperextension injury or compressive forces due to hemorrhage or edema in the central spinal cord. It usually occurs at the cervical spine. It may also occur in individuals that have cervical spondylosis who have sustained a cervical hyperextension injury during a fall or a motor vehicle accident. So the characteristics of a patient with central cord syndrome is going to be, there's going to be greater upper extremity involvement than lower extremity involvement. The patient may be able to walk, but will present limitations with upper extremity motion due to distal upper extremity weakness. And the reason why there is more involvement in the upper extremities more so than the lower extremity is because the cervical tracts of the upper extremity are more centrally located than those of the lower extremities. Then we have anterior cord syndrome, and anterior cord syndrome is typically caused due to a cervical flexion injury. So it's going to cause damage to the anterior portion of the spinal cord. That compression of the anterior cord from can be due to fracture, dislocation, or cervical disc protrusion. So the characteristics of this is going to be loss of pain and temperature due to damage to the spinal thalamic tract, complete loss of motor function due to cortical spinal tract damage, and preserved proprioception, discriminative touch, and vibration, because that is more so on the posterior aspect, not the anterior aspect. So similar to your CVA lecture, you have to be aware of what areas are responsible for what functions within the body in order to know how your patient is going to present. So here, the damage is to the anterior cord, so the posterior columns are spared, so that's why the proprioception, the discriminative touch, the kinesthesia, the vibration sense are all going to be preserved because that area is not being affected with this type of spinal cord syndrome. Then we have posterior cord syndrome, which is really rare. The characteristics are going to be, if you recall from the anterior cord syndrome, what was preserved is now not being preserved. So there's going to be a loss of the posterior columns with preservation of motor function, but now what is going to be lost is going to be proprioception, vibration sense, sometimes deep touch. So this patient is going to present with a wide base steppage gait or ataxic gait, and there's going to be an intact pain, light touch, and sensation because the anterior columns are going to be spared with this type of injury because this is only affecting the posterior cord. Then we have cauda equina syndrome. Cauda equina is, please make sure that you know that cauda equina is going to be that lower motor neuron lesion. It occurs with injuries below L1. There's going to be some flaccidity with no reflex activity below the level of the lesion. It is a lower motor neuron, meaning that there's going to be hyporeflexia, right, or hypotonia because it is a lower motor neuron lesion. There's going to be lower extremity paralysis and or paresis is variable, really depending on the extent of the injury. Cauda equina lesions are peripheral injuries. Once again, please know that it is a lower motor neuron lesion. And because they are a peripheral nerve injury, they have the potential to regenerate like peripheral nerves in any other part of the body. So now that we talked about the syndromes and why the syndromes are caused and what their patients are going to present like, we're going to talk about some general clinical manifestations when dealing with patients with spinal cord injury. So, as you know, spinal cord injury results due to a disruption of communication from the higher centers in the central nervous system to the periphery. This disruption is going to result in loss of motor and sensory function as well as impaired autonomic function. So, some of the manifestations that we're going to be talking about are spinal shock, motor and sensory impairments, autonomic dysreflexia, hypertonia with spasticity, cardiovascular impairments, impaired temperature control, pulmonary impairment, bowel and bladder dysfunction, sexual dysfunction, as well as indirect impairments and complications. So the first one we're going to talk about is spinal shock. And immediately following a spinal cord injury, there's going to be a period of areflexia that is a part of spinal shock. So the characteristics of spinal shock include reflexes that are depressed or absent. There is going to be some flaccidity, loss of sensation is present, loss of motor function, and impaired autonomic regulation. So there's going to be hypotension, loss of control of sweating, and piloerection. And piloerection is just goosebumps. This may last several hours or it may last several weeks, but it's typically or usually gone within 24 hours. So please know the characteristics of spinal shock. The second clinical manifestation is going to be motor and or sensory impairments that we have been talking about pretty much since the beginning of the lecture. There's going to be complete or partial loss of muscle function below the level of the lesion. There's going to be impaired or absent sensory function below that level of the lesion. The clinical presentation, once again, depends on the specific lesion. It also has to do with the level of the lesion as well as if it's a complete or incomplete lesion. And this is where the ASIA scale comes in to kind of classify that patient's spinal cord injury. So number 3 is autonomic dysreflexia, and I put there on the slide that this is a skills check. So make sure that you feel comfortable and that you feel confident as to defining what autonomic dysreflexia is and what your response to this medical emergency is going to be. So this is a pathological autonomic reflex that can be life-threatening to our patients. It can lead to subarachnoid hemorrhage. It can lead to cardiac arrest, seizures, and death. So it is more common in patients with spinal cord injuries above the level of T6. It can happen in incomplete, but most of the time it happens in complete injuries. It can also happen below T6 as well. So it is caused by a noxious stimulus below the level of the lesion, which may include bowel and bladder distension or irritation. So this irritation or distension typically is caused by a catheter that is blocked, by bladder distension, urinary tract infections, kidney stones, or irritation of the bladder or the urethra during catheterization or other procedures. Can also be caused due to pressure sores below the level of the lesion. Any noxious cutaneous stimuli below the level of the lesion, what that means is any restrictive clothing. If the patient has on some compression stockings that are just too tight, they may elicit autonomic dysreflexia. If the patient has a belt and the belt is too tight, or if the abdominal binder is too tight, this may elicit symptoms of autonomic dysreflexia, which is going to be that abnormal response, that abnormal reflex response of the autonomic nervous system. Kidney malfunction may also cause it. Electrical stimulation below the level of the lesion may also cause, and sexual activity, labor, skeletal fracture below the level of the lesion may also cause symptoms of autonomic dysreflexia. So it is very important to know the symptoms and that these symptoms are of sudden onset. You could be working with a spinal cord injury patient in the gym and all of a sudden they start saying that they have an excruciating headache. If you take their blood pressure is going to rise. They're going to have increased spasticity. They're going to have apprehension and restlessness. They're going to be very anxious. There's going to be vasodilation or flushing above the level of the lesion, while below the level of the lesion, there's going to be vasoconstriction. So it's going to be extremely, it's not going to be even. There's going to be things happening above the lesion while things are going to be happening below the lesion. And this is all due to that noxious stimulus that we talked about in the prior slide. Other symptoms are constricted pupils, nasal congestion, piloerection, or also known as goosebumps, blurred vision, bradycardia, and diaphoresis. So these are the symptoms that you should know to look for when you are dealing with patients with spinal cord injury because they are at risk of developing this life-threatening situation. So if you have a patient that is presenting with those symptoms that I just covered, what you need to do is make sure that you recognize these symptoms, you assess the blood pressure to see if there is something that is abnormal. You're going to call for help. You're going to follow the facility's protocol. Some facilities will activate that emergency code or even call 911. If the patient is in a supine position, you have to bring the patient to sitting to lower that blood pressure at least 45 degrees and loosen any tight clothing. So if they have compression stockings, you have to remove them. You have to take off any abdominal binders that the patient may have on. You have to identify to see if you can find what is causing this autonomic dysreflexia. So you have to see if you check the bladder to see if it's distended. You want to begin obviously with the urinary system. So you want to look to see if there's a kink in the Foley, if the tubing is bent. You have to undo any clamps. You have to check to see if the catheter, if the indwelling catheter, if there's an obstruction in it, and you want to remove any type of blockage immediately. If you cannot find the stimulus or what is causing this change in the patient, you need to call nursing so that they can drain the bladder, or if they can do intermittent catheterization. If no Foley is present, the bladder may need to be emptied, but that is something nursing would do. Pharmacological intervention may be used to lower the blood pressure if the symptoms do not subside after removing any type of noxious stimulus. You want to, after the episode, you want to continue to monitor blood pressure and you want to document and inform the physical therapist as well as the MD of the symptoms, the stimuli that was causing this, what relieved them from this once you remove the stimulus, the noxious stimulus, as well as what the blood pressure was. And obviously educate the patient on doing self-checks as well. So our next one here is a cardiovascular impairment, and it is another one of your skills checks, and it is orthostatic hypotension. Orthostatic hypotension, you've heard about in the past. It is a decrease in blood pressure, typically for the systolic 20 or more, and for the diastolic 10 or more millimeters of mercury. That's how much it should drop in order for it to be considered orthostatic hypotension. It occurs when that patient assumes an upright position, whether it be from supine to sit or sit to stand. It is caused by a disruption of the balance between the sympathetic and the parasympathetic input. It can also be caused due to a lack or a decrease in muscular contractions, and if that patient has been in bed for a prolonged period of time. Significantly, it happens in patients with spinal cord injuries above T6. So symptoms are going to be pallor, nausea, blurred vision, ringing in the ears, lightheadedness, and fainting. So what do you do? This is what your skills check is going to consist of. It is going to consist of gradually and slowly progressing that patient to the upright position to allow for the cardiovascular system to adapt to a more vertical position. So rather than bringing that patient immediately into that seated position, when you know that this patient has orthostatic hypotension, you're going to gradually bring them and progressively put them into that upright position. The abdominal binder or compressive stockings may also help as well with this cardiovascular impairment. And you obviously want to reverse symptoms by returning the patient to the original position if they do not recover. So you have to, if they're having these symptoms, you want to go ahead and put them back into the position and then try again, maybe a little slower, progressing them into that final position that you want to have them in, whether it be seated or standing. Interventions that we can also use are reclining wheelchair or elevating wheelchair that can slowly go into that upright position, or using the tilt table, as you guys had a chance to review that and use that in patient care. So the next one here is spastic hypertonia. There is going to be presence of flaccidity during spinal shock, and then it turns into spasticity. More common in patients with cervical level lesions. It is part of an upper motor neuron syndrome, just as you know that spasticity, muscle spasms, hypertonia, increased DTRs, and clonus are all part of upper motor neuron syndrome. It emerges below the level of the lesion, and about 50% of patients with spinal cord injury report that their spasticity is very problematic to them. They may learn to trigger spasticity to assist with function, so some patients will take advantage of spasticity in order to be a little bit more functional. If spasticity interferes with function, then there may be medical management. So orally, they may take muscle relaxants, they may have intrathecal injections or baclofen pump, or intramuscular injections of botulinum neurotoxin, that is Botox. So as you know, Botox is used to bind to the nerve ending at the point where the nerve joins a muscle to block the release by the nerve of a chemical that is going to make that muscle contract or more spastic. So just as they use the Botox on your face to kind of relax those wrinkles, they use it in the same way for spasticity. They use it to make sure to bring that spasticity down if the spasticity is not helping the patient with their function. Number 6 is going to be impaired temperature control. So after spinal cord injury, the hypothalamus can no longer control cutaneous blood flow or the level of sweating. This autonomic dysfunction is going to result in loss of the ability to regulate temperature or thermal regulation. The ability to shiver is going to be lost below the level of the injury. So vasoconstriction response does not occur with cold because the patient has an impaired thermal regulation. Hyperthermia due to lack of sympathetic control of their sweat glands is also going to be present in these patients. So the impaired ability to sweat below the level of the lesion is going to affect the ability of the patient to normally cool off when they are in a hot environment, and it is going to cause excessive compensatory diaphoresis. So there's going to be a lot of sweating above the level of the lesion. So it's going to be, just to sum up what I just said, there's going to be impaired ability to sweat below the level of the lesion because of that affecting of that normal cooling. And this is going to cause excessive sweating above the level of the lesion. So above, they're going to be sweaty, and below, they're not going to be able to sweat. So also vasodilation response does not occur with heat. Therefore, these patients, it's very important that we do not use any thermotherapy or modalities that are going to have to require this temperature control because of obvious reasons. The patient is not going to be able to thermoregulate. All right, so on this next slide, we're going to talk about respiratory impairments post spinal cord injury. And for the most part, we talk about the C1 through C8 level because these are the levels that include the diaphragm, and that's what we're looking for, the diaphragm and the accessory muscles, to see when they start being innervated. This innervation is going to produce the motor response for those muscles. So therefore, the patient may be able to breathe on their own, may need a ventilator. All depends on the level of the injury. So level C1 through C2, the phrenic nerve innervation and spontaneous breathing are lost in this patient. So this patient is going to require a ventilator or phrenic nerve stimulation. The only muscles of respiration that are innervated are the sternocleidomastoid, the upper trapezius, which are the accessory muscles of inspiration. Therefore, since only accessory muscles of inspiration are innervated, expiration is going to be passive in this patient. Then we move on to C3, C4 level, where there is partial diaphragm innervation. There is also some scalene innervation as well as levator scapulae innervation. So this patient may require mechanical ventilation, but with recovery and training, the patient may be able to breathe on their own, but they may require the use of a part-time ventilatory support, especially with those at C3 level. Level C5 to C8, now the diaphragm is fully innervated, as well as many accessory muscles. Cough is usually weak, but it is present, and they are not likely to require a ventilator. It is important to know that patients with injuries below T10 are likely to have near normal ventilatory and pulmonary function. And I gave you there on page 864 of your book, there is table 20.2 that states that the intercostals are innervated at T1 through T5. Therefore, breathing is going to get better. And then the abdominals are innervated at T6 to T11. Therefore, anything below the level of T10, that patient is going to have really good ventilation as well as pulmonary function. All right, guys, so now we're going to talk about bladder dysfunction, and dependent upon where the level of the injury is, it is going to kind of guide you into whether your patient is going to have a reflexive bladder or a reflexive bladder. A reflexive bladder is happening where the injury is above the conus medullaris and the sacral segments. Therefore, that's going to make it an upper motor neuron lesion. That upper motor neuron lesion is going to make that patient's bladder spastic, which means that that bladder is going to contract and reflexively empty in response to a reflex. And that reflex is typically when that bladder feels that it's full, it's going to automatically void. Therefore, this patient is going to be incontinent. Then we have the areflexive bladder, which happens below the conus medullaris or at the conus medullaris or the sacral segments. This would make it a lower motor neuron lesion. So lower motor neuron is going to make that bladder flaccid. Since that bladder is flaccid, there's going to be no reflex action of the detrusor muscle to void that bladder. So this patient would probably require a catheter in order to empty that bladder because the muscle is not being activated due to that flaccidity. So on the right side, we have some bladder training techniques, and the goals of these bladder training techniques are to control incontinence, to control the bladder, and to eventually discontinue the need for an indwelling catheter if possible. Some strategies are intermittent catheterization, where typically 2,000 milliliters are extracted from the bladder every 4 hours. There may be put on a established fluid intake pattern for that patient. They may have regular emptying at predictable intervals. So this plan right here is one that we use at our hospital, and it's called the Bumblebee Training Program. Um, don't know why they call it a bumblebee, but typically they take the patients that have bladder dysfunction to the bathroom every couple of hours on a set schedule to try to control that void. Also, we can do suprapubic tapping, which is appropriate for reflexive bladder, so it's just tapping above that pubic area, or suprapubic catheter, which is a surgically inserted catheter to assist with voiding. All right, guys, and now we're going to talk about bowel dysfunction. As with bladder dysfunction that we talked about previously, bowel dysfunction is going to be a major concern also after spinal cord injury. So, bowel dysfunction has a large impact on the patient's social activities and quality of life. So, it is something that is very prevalent in patients with spinal cord injury. It is important to know, just as with bladder dysfunction, there are spastic bowel and flaccid bowel. So the spastic bowel is going to be with spinal cord lesions above S2. There is going to be the spastic or reflexive bowel. This is an upper motor neuron lesion. Therefore, there's going to be reflex defecation that can occur when the rectum fills with stool. So this patient is going to be voiding that defecation not when he or she wants to, but when that fills with the stool. So it's going to be, once again, there's going to be an incontinence due to that spasticity in the bowel that is happening. On the other hand, we have where the lesions are from S2 to S4, or at the cauda equina lesion. These are lower motor neuron lesions. With lower motor neuron lesions, we have flaccidity of the bowel. So the bowel will not reflexively empty. Therefore, the feces may become impacted in there. Incontinence may occur due to external sphincter being flaccid. So, what is the goal for these patients? The goal for these patients is to create a safety and appropriate bowel care routine. So, we want them to have a regular pattern of bowel evacuation to prevent impaction. So, a bowel program utilizes reflex bowel management strategies such as using suppositories, digital stimulation, stool softeners, manual evacuation, making sure that the patient has an appropriate diet and obviously enough fluid intake. So all of these are strategies to get that patient to have proper bowel management. So this next one we're going to be talking about is sexual dysfunction, and people with paralysis report that improving their sexual function is the primary factor that would improve their quality of life. People with tetraplegia, it is the second most important thing after regaining the use of their hand. So it is very important part, and it will be an important part of an individual's sense of self-esteem and their overall well-being. So, for male and female responses are directly related to the level and the completeness of the injury, dependent upon if it is an upper motor neuron lesion and a lower motor neuron lesion. Also, it depends if it is a complete versus incomplete lesions. So, there's definitely going to be more of a good prognosis if the lesion is incomplete. If it is an upper motor neuron lesion, which is above the conus medullaris, versus a lower motor neuron lesion, which is the conus medullaris and the cauda equina. So for the upper motor neuron lesions, the reflex arc is going to remain intact, but the psychogenic response is going to be lost. So in order for this patient to have those components of sexual arousal, with this upper motor neuron lesion, since the reflex arc remains intact, then they can get the sexual arousal through external stimulation, both in men and women. But the psychogenic aspect of it is going to be lost. And when we talk about psychogenic, I want you to think of activities that are through cognitive activities such as erotic fantasy. So this comes from the higher centers of the brain, and that for patients with upper motor neuron lesions, spinal cord injuries are going to be missing. Therefore, the only way for this patient to get sexually aroused would be from external stimulation. Now, with the lower motor neuron lesions, now it's the opposite. The reflex arc is going to be lost. Therefore, the only way that this patient is going to have these components of sexual arousal are going through to be through psychogenic responses. So through cognitive stimulation, your book gives an example as I mentioned before, erotic fantasy. It can be through medications, or devices or topical agents may also work for this patient. So fertility is the next topic we're going to be talking about, fertility and pregnancy. So female fertility is not affected as severely as the fertility in men with spinal cord injury. So the labor and delivery, if the patient with spinal cord injury gets pregnant, then there may be impaired respiratory function, which will lead to complications. There is obviously impaired sensation, so the labor is not going to be perceived. Labor may cause dysreflexia. Contractions are not going to be affected because these are controlled by hormones. So paralysis is not going to be an issue when it comes to contractions. But paralysis does affect the ability to bear down, which will prolong labor and increase difficulty. So these patients are at a risk for having to have a C-section. All right, guys, so now we're going to be talking about some secondary medical complications, and the first one being pressure sores. And you are familiar with pressure sores, and the causes are going to be unrelieved pressure, specifically in bony prominences, or shearing forces that will tear the skin and then therefore lead to a pressure sore. Contributing factors obviously is going to be the loss of sensation, the inability of that patient to change positions, non-compliance with skin care from the patient or from the family members or caregivers, spasticity, which causes those shearing forces, moisture in the skin, which will cause maceration. For example, the patient is sitting in their soiled sheets because of their incontinence and they're not wearing a diaper, or their diaper has gotten too soaked. Nutrition, so poor nutrition or low protein, patients that have are anemic, or secondary infection. So in order to prevent these pressure sores from happening, specifically talking now about patients with spinal cord injury, they should be turned every 2 hours. There's usually a turning schedule in the patient's room when they are in an inpatient facility. Wheelchair pressure relief is very important to teach these patients. First, showing them passively with our help, and then eventually they will be able to do the pressure relief on their own. Making sure we educate the patient and the caregivers to monitor the patient's skin for increased moisture or increased maceration, and obviously instructing the patient on skin inspection utilizing a mirror if that is possible. Education is extremely important for both the patient and the family members or caregivers, and positioning is often viewed as we are just being really annoying and we're bothering the patient and interfering with their lifestyle and their sleep position that they like to take. But it is a very important part of our education, because if it can just go bad in just one day with the patient, where the patient sits in skin macerated skin for X amount of hours in one day. So we have to, regardless of the fact that the patient may think that it is an annoying part of education, it's definitely something that is very important. And obviously, wound care is very important. Once the patient does start to get an area of ischemia because of unrelieved pressure, definitely the sooner that it is starting to be treated, the better. The more of a better prognosis the patient has by taking care of that pressure sore. Deep vein thrombosis, or DVT, is one of the other secondary medical complications. It is very important for you to be familiar with the signs. So, local swelling, erythema, and heat are typically some of the signs that you will see. Contributing factors to this are immobility, loss of that normal pumping mechanism with active contraction, the patients that are in prolonged bed rest and there's prolonged pressure, or loss of the vasomotor tone. So the intervention medically, anticoagulation medications are given. PT should be placed on hold to avoid that thrombus to become an embolism. So prevention is key with early mobilization, turning to avoid pressure over large vessels, passive range of motion, support stockings, and positioning for venous return are all prevention strategies to prevent the development of a DVT. So the next secondary medical complication is pain, and pain is a common occurrence following spinal cord injuries, both in the acute and even chronic stages of recovery. Pain can be divided into two broad categories. The categories are the ones that we see on here: are nociceptive pain, which is pain that has an origin from the musculoskeletal or visceral, and we have neuropathic pain, which is pain that can be below, at, or above the level of the lesion. So let's start with nociceptive pain. The most common areas that are painful are going to be the shoulder and other joints and soft tissues. So this pain can be in the shoulder, it can be in the wrist, the elbow, involving the capsule, the tendon, the ligament, and muscle tissue. And this is typically caused by a variety of factors. More so in spinal cord injuries, this can be due to mechanical injury, inflammation, muscle spasms, and these muscular imbalances are usually seen due to overuse or poor posture. That patient may be sitting in a wheelchair, so that is going to decrease their flexibility in certain areas. They may have incorrect positioning in their bed. So this can all contribute to that nociceptive pain. Some of the some of the specific musculoskeletal injuries that may occur are the ones listed here: biceps tendonitis, rotator cuff tears, carpal tunnel syndrome, and wrist tendonitis. Now, when we talk about neuropathic pain, we are referring to pain that is caused by injury to the central or peripheral nervous system. It can occur, as it states in the slide, at the level of the lesion, above the level of the lesion, or below the level of the lesion. So neuropathic pain below the level of the lesion is due to spinal cord damage and may take the form of allodynia. Allodynia is the experience of pain from a non-painful stimulation, or they may have hyperalgesia, which is increased sensitivity to pain that is caused by damage to the nociceptors. Okay, the patient may also present with radiculopathies. So in order to treat these types of pain, we know about our modalities that we can use. So TENS, massage, mental imagery, biofeedback, acupuncture, meditation, as well as it can be treated with the use of medications. So as you can see here, that some modalities are missing, and it's obviously going to be our heating modalities, because the neuropathic pain is typically caused by injury to the central or peripheral nervous system, so we don't want to put any type of heating modalities in this area. So the next one is going to be contractures, and contractures develop secondary to prolonged shortening of structures across and around the joint, which will lead to limitations in that joint's motion. So the contributing factors for your patients that present with contractures are going to be the lack of active movement, lack of active muscle contraction, spasticity, or gravitational forces on flaccid muscles that put them in certain positions, and therefore it may lead to the contracture of those muscles. So the key is going to be proper positioning, um, range of motion, and splinting. So this will prevent the patient from developing these contractures. So very important to know what the prevention strategies are going to be. So the next thing here we're going to talk about is heterotopic ossification, and it is an abnormal osteogenesis or bone growth in non-skeletal tissues, typically near the joints, which develops at 3 times the normal rate. This will result in jagged edges, and it occurs at the level of the lesion, um, typically around 3 to 12 weeks post spinal cord injury. The cause of this is idiopathic. Factors associated will include patients that have complete injury, trauma, severe spasticity, urinary tract infection, pressure sores, as well as immobilization, muscle spasms, and lack of oxygen or inflammation. It is most commonly seen in the hip and the knee joints, and the signs of this are going to be swelling. There's going to be decreased range of motion over a short period of time, typically within a day. There may be erythema as well as localized warmth in the area. So in order to manage this abnormal osteogenesis, it may be treated with medications. It may be treated with anti-inflammatories to have been used in preventing the formation of heterotopic ossification. Also, range of motion, and you want to take special care when you're performing passive range of motion on these patients, because if it is too vigorous, it may cause trauma, because as you saw in the first point that I made at the top of the slide, it may result that abnormal growth may result in jagged edges, which may cause trauma to the surrounding soft tissues where this bone growth is growing that it's not supposed to be. The next one here is osteoporosis, and individuals with spinal cord injury may experience a significant amount of bone loss early after injury and then long term. And this is a rapid mineral bone loss in the first 4 to 6 months post injury. This is due a lot to the prolonged lack of mobility and the prolonged lack of weight bearing. Therefore, the density in the bones is going to decrease and may lead the patient to be diagnosed with osteoporosis. And the final one that we're going to be talking about is syringomyelia. And this is a disorder in which a cyst forms within the spinal cord. And you see a diagram here to the right where you see that formation of that fluid-filled cyst. It's called the syrinx, and it expands and it elongates over time, which destroys a portion of the spinal cord from its center and then expands outward. So this is syringomyelia, and the name of the cyst is called the syrinx. All right, guys, so this is the end of the first part of the spinal cord injury PowerPoint. The second part is covering the medical management and rehab interventions that we're going to be practicing in some of the equipment that we are going to be seeing during the lab. It is also very important for you to start reviewing the levels of the spinal cord injury, and based upon the levels and the muscles that are innervated at those levels, you should be able to tell what your patient can and cannot do as far as function goes. So that is going to be the main focus of the second part of the spinal cord injury lecture.